Hi, and welcome to week 2 of PN107. Psychopharmacology is our topic today. And if you follow along in your PowerPoint, let's get started. So, our learning objectives for this week are to explain the functioning of a synapse and the purpose of our monoamine neurotransmitters, monoamine, describe the key differences between the various neurobiological causes of mental illness, differentiate psychotherapeutic medications according to what disorders they are primarily used to treat, explain the serious side effects of psychotherapeutic medications, and explain the need for detoxification protocols while providing care in an interprofessional team. So, our overview: mental illness is an expression of the interaction between neurobiological, genetic, and environmental factors. And the brain has complexity. The exact pathophysiology of mental health disorders remains largely misunderstood, but we know that it includes chemical function, anatomical function, neurotransmitters are functioning of these. The neurotransmitters can be manipulated through pharmacological and non-pharmacological interventions. So, key point for this lesson, we're going to understand the anatomical and chemical functioning of the brain. And then there's a section in your ATI that explains the key differences among the various neurobiological causes of mental illness. And the nurse's understanding of the efficacy of the various medications for mental health treatment is significant in addressing the stigma related to mental illness. So, key terms, we have neurons, cells that are prevalent in the brain and have a role in sending and receiving electrochemical messages. Mental wellness is an outcome of a properly functioning brain. So, there are many factors that can impact a brain's ability to function, such as neurobiological and environmental factors. We're going to discuss the neurobiological and environmental functions of the brain throughout these slides and how each of these impacts our brain's ability to function. Neurotransmission is a function of electrochemical messages that are sent and received from various anatomical components of that neuron. And that presynaptic neuron, which is on the next slide, will send a key or what's called a neurotransmitter that fits into the lock, which is a receptor site that instructs the postsynaptic neuron on how to function. So different neurotransmitters like serotonin and dopamine only fit into the receptors for serotonin and dopamine. So it's a key that only opens one certain kind of lock. And then after that instruction is received, the neurotransmitter will be stored for future use. So we have the neurotransmitter itself, which is the chemical components that the neuron sends and receives, which can excite or inhibit processes in the cells by acting as a key and lock system. And then we have reuptake, is the process in which the neurotransmitter is reabsorbed by the synapse that secreted it. And then we have deactivate and inactivate, and that's the process of inactivating neurotransmitters through enzymes such as the MAO, which is an enzyme responsible for deactivating that particular monoamine neurotransmitter. Okay, on the next slide is a beautiful picture of that presynaptic neuron and the postsynaptic neuron, and you can see all the little chemicals that are kind of hanging out in there. So we'll look at these numbers. So number 1, that's the neurotransmitter released from the presynaptic neuron. And the number 2 over here, that is the neurotransmitter binding to the specific receptor. And we look at 3. You see there's 3A, B, and C. So 3A is returning the presynaptic clef reuptake channel. So A is being stored for later use. B is being deactivated, so the enzyme degrades the neurotransmitter. Or C, it's diffused away at the connection. And then this number 4 over here, that's binding to a specific receptor on that neuron for feedback regulation. So the key point for this particular slide is the chemical components that the neuron sends and receives. They're called neurotransmitters. And although it's not exclusive to the brain, neurotransmitters function as one of the main components of how our body communicates with itself. So, next slide, we're looking at your neurotransmitters. So, the chemical components of the neuron are called neurotransmitters, and these send and receive these electrochemical messages. They are not exclusive to the brain, like we said in the last slide. So, neurotransmitters, we're looking at dopamine. And dopamine is your excitatory neurotransmitter. It's responsible for transmitting information about emotional responses, complex movements, and your cognition. It's responsible for individual experiencing pleasure and reward from behaviors, and its neurotransmission can be affected by stress. Manifestations of schizophrenia can be ascribed to levels of dopamine and other neurochemicals of the brain, while dopamine and antipsychotic medications used to treat schizophrenia aim to regulate that neurotransmission of dopamine. And if you want to read more information about this particular disorder with the dopamine, you can go to your Schizophrenia Spectrum Disorders and Psychosis section of the ATI book. Your serotonin, now that is a inhibitory neurotransmitter. Remember, dopamine was excitatory, so serotonin is inhibitory neurotransmitter. It's responsible for emotional regulations, your sexual behaviors, your temperature regulation, sleep, and pain management. More than twice as many receptor sites than many of the major neurotransmitters, and contributing to the variety of disorders such as anxiety, depression, and psychotic disorders. So for more information about how serotonin can affect different regulations in the body, you can go to the Mood Disorders and Suicide chapter in your ATI book. Then we have norepinephrine. This is also an excitatory neurotransmitter. It's responsible for learning, sleep, mood, memory, and attention. It is the most common neurotransmitter in the nervous system and is a derivative of epinephrine, which is also an excitatory transmitter. It's responsible for our response to stress, and individuals with a history of trauma can have increased levels of norepinephrine, which leads the individual to experience some of the manifestations of trauma-related disorders like anxiety and depression. We also have in our list here histamine. It has a very unique role in neuromodulation. And so in that pre- and post-synaptic receptors for histamine, it regulates the release of histamine, but it also controls the release of glutamate, serotonin, and the GABA, the gamma-aminobutyric acid. The known postsynaptic receptors for histamine in the brain mediate the effects of alertness and wakefulness. And so many medications used to treat mental illness are histamine antagonists, which result in side effects like sedation and weight gain. Then we're going to look at that GABA. It's an amino acid that serves as an inhibitory neurotransmitter. So similar to histamine, GABA modulates other transmitters. In addition to the neuromodulation, GABA promotes neuronal development It improves sleeplessness, and it minimizes the manifestations of depression. Medications such as your benzos or your BZDs, like Xanax, aim to enhance the binding of GABA to an associated receptor, thereby reducing manifestations of anxiety and inducing sleep. Then we have glutamate, and glutamate is an amino acid that serves as an excitatory neurotransmitter. Dopamine interacts with glutamate in various areas of the brain, and it regulates motor, affect, and cognitive function. And we have acetylcholine, or ACH. It's a neurotransmitter that is inhibitory and excitatory, with receptors found throughout the body, but it's particularly found in abundance in your skeletal muscles. So it regulates our sleep-wake cycle. It is a primary neurotransmitter for muscle functioning. Individuals with neurocognitive disorders like Alzheimer's disease are found to have decreased amounts of this ACH secreting neuron. Medications used to increase the concentration of acetylcholine to improve neurotransmission in clients. So there's our Alzheimer's medication are specifically targeting that acetylcholine. All right, your next slide is your neurobiological causes of mental illness. Much of the etiology of manifestations of mental illness is still extremely unknown. Research suggests that mental illness can be inherited and the result of multiple environmental factors such as exposure to stress and trauma. Neurobiology studies how the functioning of the brain impacts behavior and attempts to answer questions related to mental health. Mental health is associated with genetics, and mental illnesses can be inherited. The following types of research studies have found evidence of genetic links to mental illness. We have the family study, that adoptive study, and the twin study. So in the family study, it was a study that sought to understand the cause of behaviors from those who share genetic history, such as having a parent or a grandparent with bipolar disorder sets up a child to have an increased risk of developing bipolar disorder. In the adoptive study was a type of study that sought to understand the cause of behaviors when comparing those who share and do not share genetic history but are raised in identical environmental conditions. And then we have a twin study, is a type of study that seeks to understand the cause of behavior when comparing genetically identical people. Your next term on that list is your psychiatric pharmacogenomic testing. And that's a strategy that a healthcare provider may choose to improve the likelihood of selecting an effective psychotropic medication based on the client's genes. This is evident in the International Society of Psychiatric Genetics. It provides prescribing guidelines on how to best use published evidence and product labels to best serve the client when genetic data is available. There's one test for if you're looking at want to look up a name brand. There's a test called GeneSight that will do this. Stress and psychoimmunology is a field of science that attempts to expand knowledge related to the impact of psychosocial stress on the body's immune system. The immune system may directly affect the processes of neurotransmission. So, for example, manifestations of depression and mood dysregulation are common when the body is experiencing an inflammatory response. Right? And then the next on your list there is infection. Mental illness can be described according to previous or current infection. Many of the studies focus on the impact of viral infections in particular, and it is theorized that a viral infection possibly alters the genetic composition in the central nervous system, which can lead to the presentation of a mental illness. There is a causal association between infection during pregnancy and the occurrence and manifestations of schizophrenia. However, none of the studies were conclusive. It's all anecdotal evidence at this point. There's neuroplasticity, and that's the brain's ability to adapt synaptic connections, particularly in response to stress or learning or after experiencing an injury. The brain has the ability to establish new neuronal pathways or go through a complete remapping in response to a stimulus. And that explains why some manifestation of mental illness increase in severity over time, such as people with major depressive disorder, and it cannot be cured through a single dose of medication. For more information about neuroplasticity, you can go to your trauma, crisis, disaster, and related disorders chapter in your ATI book. So your next slide shows the neuroplasticity with the chemical change, structural change, and functional change. So the adaptive process of neuroplasticity, it's not instantaneous. It takes weeks or months for the brain to configure or reconfigure these particular pathways. So in a chemical change, the neurons first respond to the new stimulus by making chemical changes. And this could also be elicited by taking medications. In the structural change, as the chemical change is sustained, a structural change then occurs to better support this new stimulus. Then we have a functional change. Once the structural change has been established, the brain experiences functional changing through the utilization of these new neuronal pathways. And neuroplasticity is covered in detail in that trauma, crisis, and disaster chapter in the ATI book. So on your next slide, we're going to talk about anxiolytics. Anxiolytic, or a fancy word for anti-anxiety medication, is used to treat the manifestations of anxiety. And if you want to go more in depth about the particular medications, go to the anxiety and obsessive compulsive and related disorders lesson in your ATI book. So different kind of drugs, medications that could be in this class are benzodiazepines. Most prescribed medications for treating anxiety are benzos, and it's most commonly found in formulas like alprazolam, diazepam, lorazepam. So when you're taking tests or you're going to take your practical nursing NCLEX, if it's a drug name and you have not heard it before, always break the drug names down, because on NCLEX they're going to give you the generic names. And for the most part, there are some exceptions, but for the most part, benzos end in like that PAM. So you'll see that a lot with different class drugs that we talk about having very similar generic names with the same root or the same ending to the generic name. We also have buspirone. Name brand used to be called Buspar. It's a very commonly used medication to treat anxiety. It's one of those ones where it either works or it doesn't. There's no middle ground. And so therapeutic use, because anytime we talk about medications, we always talk about what is their indication, what is their therapeutic use. So benzos regulate the function of that neurotransmitter GABA. Benzos will bind to that GABA receptor site, causing an influx of chloride to enter the neuron, and that produces an inhibitory effect. A cascade effect will then occur when the benzos are introduced into the brain, causing a large amount of dopamine to be released into the limbic system. This effect greatly increases the potential for physical dependence on benzodiazepines. They have an extremely high abuse rate and addiction rate. especially the Xanax, because it has a very short half life. So it is a very common benzo to see on being sold on the street. But unfortunately, with the influx of drugs coming across the southern border, our Xanax bars or Xanny bars or whatever the street name is for them usually are contaminated with either MDMA or with fentanyl. So, adverse effects, benzodiazepines, so manifestations related to that inhibitory response are very common. And we're looking at the central nervous system depression that can happen. So, we're getting sedation, poor concentration, impaired memory, and drowsiness. And you can have next day sedation, which is a prolonged effect of some of these medications that have a longer half life. And some people have a paradoxal response where they have the complete opposite reaction to the medication's intended purpose. This puts a patient at an extremely high risk for falls. So, any of your patients that are on benzodiazepines, they should be on fall risk precautions. And we can have benzodiazepine toxicity. So, um, we should always have the antagonist, which is flumazenil, which can reverse this, sedative effects of a benzo. But the caution there is that it can induce seizures in clients who have a history of seizure disorders and also patients that are taking tricyclic antidepressants. So we need to actually always be careful, and we need to do good medication reconciliations and know what patients are taking at home. And then looking at the buspirone, that is a partial serotonin receptor agonist, and it is a very weak dopamine receptor antagonist. It does not affect the GABA receptors at all, but the clinical effects of buspirone, they take a very long time to build up in the system. So it's almost like the buspirone becomes like an adaptive response in the brain, and that's how it helps control chronic anxiety versus a benzo going after more of an acute anxiety. And somebody's going to have an MRI, they're claustrophobic, we give them a low dose of a benzo, it's an acute anxiety. Patient's about to go into surgery and they're very anxious, so they might give them a little bit of Ativan to kind of calm them down for an acute anxiety. For someone who has chronic anxiety, everyday anxiety, using benzos is not recommended because benzos were never meant to be taken every day. If somebody is that anxious, they need to be on a different class of medication. So, teaching anxiolytic medications are only treating the manifestations of anxiety. They don't treat the root cause of the anxiety. Benzodiazepines potentiate the effects of alcohol, so the two should never be consumed at the same time. You need to educate your patients that the sedating effects can be very disruptive. Client activities should be planned accordingly. Prolonged use of benzos, the body will adapt and become tolerant and dependent on the substance. Never abruptly discontinue prolonged use of benzodiazepines. The patient needs to be tapered, and there's a risk of developing an addiction with that prolonged use. On your next slide, it's talking about antidepressants. So we have different categories, and they're listed there on your slide. We have your MAOIs, we have your TCAs, we have your SSRIs, we have your SNRIs, and then there's a bullet for other medications. Other medications is looking at like trazodone, mirtazapine, and bupropion, because they don't fall into those four major classes of antidepressants. So, therapeutic use, mechanism of action, antidepressant antidepressant medications are used to treat a variety of manifestations of depression and anxiety. Some work a little better for depression, some work a little better for anxiety. The DSM 5 identifies various disorders that present with those manifestations. We have major depressive disorder, generalized anxiety disorder, post traumatic stress disorder, bipolar disorder. So, MAOIs, very powerful medication, not very widely used anymore. That is a mechanism of action, is that it inhibits the function of that enzyme, that monoamine oxidase enzyme. So tricyclic depressants came out after MAOIs, so they've been around for quite a while. Also not as widely used, but great medications for various purposes. That is a type of antidepressant in which the mechanism of action affects the serotonin and the norepinephrine by blocking their reuptake at those presynaptic receptors. So you'll see TCAs used a lot for people with that also have some neuropathic or some kind of peripheral neuropathies or things where there's a lot of nervous system type pain. Selective serotonin reuptake inhibitors, SSRIs, are a type of antidepressant in which the mechanism of action affects the serotonin by selectively blocking that reuptake on the presynaptic receptors. So this allows for more serotonin to kind of hang out and be utilized by the body. Then we have SNRIs, so serotonin norepinephrine reuptake inhibitors, also a type of antidepressant. Mechanism of action is in affecting the serotonin and the norepinephrine by selectively blocking the reuptake in those presynaptic receptors. Adverse effects, because they have to have them. Every single drug has an adverse effect. Most common side effects: weight gain, daytime sedation, sexual dysfunction, and insomnia. Very common for our MAOIs. For our tricyclic antidepressants, they are blocking cholinergic receptors. So you're going to get anticholinergic type effects like a dry mouth. You can get constipation. There's a risk for orthostatic hypotension. So since the side effect is constipation, sometimes you'll see TCAs used for patients who have IBS with diarrhea, because if the side effect is constipation and the patient has chronic diarrhea, they kind of start to normalize the bowel a little bit. So over time, though, patients can develop a tolerance to the anticholinergic effects. Selective serotonin reuptake inhibitors, common side effects: nausea, agitation, and sexual dysfunction. And your serotonin norepinephrine reuptake inhibitors, very similar to SSRIs, but a unique side effect is sometimes they have appetite suppression. So anybody beginning or increasing the dosage of any antidepressant should be watched closely for worsening depression or any type of unusual behavior like suicidal thoughts or ideation. So things we need to teach: it's going to be a few weeks to experience relief of what we're trying to treat. If it's the anxiety or the depression, I give patients about 2 weeks. I usually bring them back into my office to review how they're doing, to see if adjustments need to be made, timing of the day, do we need to cut the dose in half, so I usually give about 2 weeks, because that tends to be the time of where I'm going to know how well they're really doing. So if the patient's getting sedated from the drug, it's better for them to take that medication at night. And if it's something where it makes the patient very awake and like it has almost like a dopamine boost, then we're going to have that patient take a very energizing drug in the morning. With MAOIs, and I see it on every NCLEX. I have seen a question on MAOIs on every single NCLEX review since I've been doing this. I think I started teaching in like 2006, and every single NCLEX review, MAOIs have been on the NCLEX. So always know what foods you can't eat if you are taking an MAOI, and it's going to be something that increases tyramine, which is one of your amino acids. So look at drugs or look at foods that contain that, because that's going to have the patient have an increased risk for hypertensive crisis. So aged cheese, red wine, things in that family. I'm sure somewhere in your ATI book it gives you a list of things you need to tell your patients not to eat. The other thing is patients taking TCAs or taking MAOIs. They can't take over-the-counter ephedrine products, pseudoephedrine, because they will cause hypertensive crisis. All right, so on your next slide, it kind of goes over some of those foods: aged or strong cheeses, your cured and processed meats, dried or overripe fruit, which also is also wine, and there's certain sauces like teriyaki, soy sauce, things that contain shrimp. Never a good idea because they can lead to a toxic amount of MAOI in the bloodstream. So anything that's aged or fermented is going to have high levels of that tyramine. And foods that are high in tyramine, uh, even beer, chocolate, avocados, soy, like tofu, edamame, no goes. Overripened fruits, raisins, prunes, bananas all contain high levels. Nothing with nitrites, so no hot dogs, no bacon, no sausage, all things that we need to tell our patients that they can no longer eat. Next class of drugs is our antipsychotics or neuroleptics. They're used to treat a variety of manifestations that are present in our schizophrenia spectrum and other psychotic related disorders. And then you can read more in depth in your ATI book. It's on the schizophrenia spectrum disorders and psychosis chapter. We have 2 generations of antipsychotic drugs: first generation, second generation. Long-term intramuscular antipsychotic medication can be given. They are usually called LAIs, like long-acting injectables, and we have ones that can be given to schizophrenic patients monthly, and there's a 6-month, and there's ones that last even longer. There's always new and emerging drugs coming out on the market. So therapeutic use and mechanism of action: first generation antipsychotics, also called our conventional or our typical psychotics, work by blocking dopamine receptors. So very potent dopamine antagonists can be effective at treating schizophrenia. The potency also causes a lot of side effects. So common first generation medications are like haloperidol or Haldol, clozapine, you'll see, or chlorpromazine are very common first generation typical antipsychotics. Then we have our second generation antipsychotics. So they are considered our unconventional or our atypical antipsychotics but they block dopamine receptors to a lesser degree, but they also inhibit the reuptake of serotonin. So this helps kind of target both sides of schizophrenia. So it goes after the positive and the negative manifestations of schizophrenia. So although they're not as potent as those first generation, they have less side effects. So there's three second generation aripiprazole, brexpiprazole, and cariprazine. Um, those three are considered, technically, they're considered third generation antipsychotics. They work by regulating dopamine and stabilizing it. So, adverse effects, most common anticholinergic manifestations like dry mouth, constipation, blurred vision, orthostatic hypotension. We can get enlargement of the breast tissue, the gynecomastia, decreased sex drive, menstrual irregularities, and weight gain. Weight gain is very, very common. It can cause a lot of metabolic issues, increasing blood sugar, increasing blood pressure, increasing cholesterol, getting the whole trifecta of metabolic disease. So we need to make sure that we monitor them very carefully. We need them to understand that they need to continue treatment even if their symptoms resolve. Some clients will feel that the side effects are intolerable, and we need to encourage them to talk with their healthcare provider about the possibility of other alternative medications that may be available to them, but we don't want them to go off of medication. We need to instruct them about the importance of going for the required laboratory testing. These patients that are on these antipsychotics, they need to monitor their blood glucose and their lipid levels while they are taking them. And they also need to look at the absolute neutrophil count if they are on clozapine. We need to encourage clients to have a support person who knows them well and helps them identify early signs of relapse so that they can get treatment before they lose control. On your next slide, it talks about mood stabilizers. They are used to relieve the manifestations of mood dysregulation, especially for disorders like bipolar. In HEI, there is a lesson on mood-related disorders. Therapeutic use, mechanism of action. Mood stabilizing properties of lithium are very, very not understood. But lithium remains a point of controversy in its efficacy when it's compared to other mood stabilizers like valproic acid. It is known that lithium has an effect on regulating the reuptake of MAO, but it can cause a lot of problems with your salt regulation. So, lithium is a very common primary medication used to treat mood dysregulation. If lithium's not well tolerated, patients usually will end up going onto anticonvulsants or seizure drugs like Tegretol or Depakote because they're very effective at treating manifestations of mood dysregulation. Valproic acid inhibits the kindling process, which is the cascading effect that causes seizure activity to increase in severity, and it's linked with episodes that produce mania, and it explains why this is effective because it's increasing the levels of GABA, and because it is increasing those levels, we should look at liver functions at these patients. Outside of acute bipolar episodes, a second generation antipsychotic, aripiprazole, as an injection, is very effective at helping a client remain stable in a maintenance phase of treatment. And then adverse effects, the most common side effects. For lithium, it's diarrhea, nausea, increased thirst, fine hand tremors, weight gain. That increased thirst comes from the salt wasting. Anticonvulsants can cause sedation and dry mouth. And depending on the anticonvulsant, the client can experience weight gain or they can experience weight loss. And we need to do a lot of education about, for female of childbearing ages, these class of drugs can cause birth defects. So we need to teach clients that despite them being in a therapeutic medication regimen, relapses are always still possible. For lithium patients, they're going to have to get lithium serum concentration levels done every few days when they first start on lithium until the healthcare provider determines that the client is stable. And the nurse should also instruct the client that they need to drink a lot more water to help the kidneys excrete lithium, because the risk of lithium toxicity is very common. On your next slide, it goes more into detail about lithium therapy. And so the properties of lithium can prevent a relapse into a manic or major depressive episode. When initiating lithium, blood testing to monitor the levels should be performed like every couple of days to, every 1 to 2 weeks, depending on how the client's responding, until we reach a therapeutic level. And then lithium toxicity is addressed later on in your PowerPoint. So considerations, we need baseline liver function tests, and we need to be aware that lithium is a salt that is produced by the kidneys, so kidney function tests should also be monitored. Lithium is a salt that's processed by the kidneys, so we need to do kidney function tests. Next class of drugs in your PowerPoint is your sedatives or your hypnotics. And we usually use these to treat sleep-wake disorders such as insomnia. So drug class, it can be your benzodiazepines, your non-benzodiazepines, and your melatonin receptor agonists. Therapeutic use and mechanisms of action. Benzos, we already talked about. Non-benzodiazepine hypnotics are used for the treatment of insomnia because they bind to the GABA receptor. Mechanism of action is very similar to benzos, but have fewer adverse side effects. Examples are RZ drugs, so zolpidem, like Ambien, or even Lunesta. Melatonin receptor agonists activate the melatonin receptors, and they are primarily used for clients who have difficulty falling asleep. And bromeltion is an example of one that helps clients fall asleep. So that's why it's always important to know what's actually going on with the client. Do they fall asleep and then have trouble staying asleep, or do they have problems actually falling asleep, but once they are asleep, then they're fine? Or do they have a combination of the both? So adverse effects of both non-diazepine hypnotics and the melatonin agonists are very similar. So headache, fatigue, dizziness, nausea. More serious adverse side effects can be like with Ambien, the patient could actually sleep drive or sleepwalk. They have amnesia, they could have hallucinations, and they could have suicidal ideation. So we have to caution our client, never take these medications prior to operating a vehicle. Always avoid the consumption of alcohol or another CNS depressant when you are taking these medications. And these are for the short-term treatment of insomnia. They're not meant to be used long-term, and we should continue to practice good sleep hygiene habits. On your next slide, they talk about stimulants. So central nervous system stimulants are primarily used for attention deficit hyperactivity disorder or a patient who has narcolepsy. So therapeutic use, produce a therapeutic benefit is the presynaptic neuron to release the dopamine, serotonin, and norepinephrine. In addition, the reuptake of these neurotransmitters is also inhibited by the stimulants. Some of the most commonly prescribed CNS stimulants are methylphenidate, amphetamine, and dextroamphetamine. So we see improvement in the reduction of hyperactivity, impulsivity, and inattentiveness when we take a CNS stimulant. Common adverse side effects: nausea, dry mouth, heart palpitations, irritability, high blood pressure. We want to monitor for decreased appetite as it could lead to weight loss. So for a child who is an early adolescent, child who's taking a stimulant, we could actually suppress their growth because they're not consuming an adequate diet. So we need to be weighing all of these clients. We need to emphasize diet considerations. Because the appetite may become suppressed, we need to make sure that the support person or the parent is useful for monitoring intake, avoiding foods that contain caffeine. If a client's taking an enteric-coated formula, then they should not take their medication after 12 p.m. because they could actually be so restless for nighttime and it will disrupt their sleep. So patients like that would need to be on an immediate release formula, not on one that's enteric coated, or extended release, coated. Then we look at some of the herbal remedies that patients might be on. Common things are St. John's wort, ginseng, chamomile, echinacea. Herbal remedies can interact with prescribed medications and cause harm to a client. Like St. John's wort, if they take that with Prozac, it can cause serotonin syndrome. So the nurse should encourage the client to disclose the use of any herbal remedies to minimize complications with prescribed medications. In the next slide, we're going to talk about that serotonin syndrome. So what is it? It's a high influx of serotonin. It's a serious drug reaction resulting in high levels of serotonin. So intentional overdose of the medication, taking multiple classes of antidepressants at the same time, mixing antidepressants with migraine meds, mixing antidepressants with pain medication, illicit use of drugs like LSD and ecstasy, or combining antidepressants with herbal remedies like St. John's wort. So nursing care for serotonin syndrome includes vital sign stabilization, sedation with some benzos, and the administration of an agonist med. Activation syndrome. This is impulsivity and suicidal ideations that present after starting an antidepressant. Common causes: initiation of the antidepressant. Very often it's going to be an SSRI that does this. It develops within the first few hours of an administration through the first few weeks of starting treatment. So clinical manifestations are irritability, anxiety, impulsivity, aggressiveness, agitation, increased thoughts of suicide. So awareness of these client behaviors may indicate that a client has decided to actually complete their suicide plan. So what happens is a person's so depressed, they don't have the mental energy to commit an act of suicide or injury to themselves. But once we have this activation syndrome and they get this surge of serotonin, now all of a sudden they have the energy. So you need to look at patients that start giving away belongings, calling friends to say goodbye, start filling out like living wills. And there's more information about this in your mood disorders ATI chapter. In your next slide, it talks about antidepressant discontinuation syndrome. So what is it? It can occur when there's a sudden discontinuation of an antidepressant medication if the person has been on it longer than a month. Difficulty sleeping, anxiety, depression, flu-like symptoms, Electric shock sensations felt in their heads. It could be very disruptive to their daily life. If they are abruptly stopping an MAOI, they could actually have a psychotic episode. And these manifestations can actually last a decent amount of time. So for nursing interventions, we need to monitor for these manifestations. We need the client to understand that antidepressants should never be abruptly discontinued. They have to be tapered off by their provider. And we need the client to express their comfort with their current medication regimen and be able to discuss possible alternatives if needed. On your next slide, it talks about lithium toxicity, and it goes over the three different types: the early, the advanced, and the severe, and the different serum lithium levels that are associated with those particular levels. If a person is in early toxicity, nursing interventions is withholding the lithium and consulting with your healthcare provider. So if you get labs back on your client and the serum lithium level is greater than 1.5, you're going to hold that med and you're going to call the provider. Things that can happen in early toxicity are neurological dysfunction like poor coordination, confusion, and sedation. We could have GI discomfort, nausea. They could start having tremors, vomiting, diarrhea. As it starts to move into advanced toxicity, you could have ringing in the ears. You can have jerking motor movements, diluted urine, blurred vision. They can start having respiratory complications. And when we jump into that severe toxicity level where the levels are greater than 2.5, they could actually deteriorate very fast into a coma, and they could have severe respiratory complications that actually leads to their death. Most patients who are in severe toxicity will end up going on emergency hemodialysis. So agranulocytosis is a life-threatening condition in which the blood has a lower than normal number of white blood cells, and this is most commonly associated with the use of clozapine, but it can happen with any antipsychotic. You can get flu-like symptoms, sore throat, fatigue, fever, muscle aches. So before starting any medication therapy with a drug like clozapine, the client should have white blood cell counts done to have their baseline data. And they should get weekly laboratory testing while they are on the medication to make sure that we are not having the start or occurrence of agranulocytosis. Neuroleptic malignant syndrome, potentially life-threatening reaction to antipsychotic drugs, characterized by fever, altered mental status, muscle rigidity, vital sign instability. Some common causes: after initial exposure or the abrupt discontinuation of an antipsychotic medication, this can happen. Haldol has a higher risk of developing this NMS. So we get muscle rigidity, hyperthermia, vital sign instability, increased or decreased blood pressure, and tachycardia. They get an elevated CK enzyme. Next slide talks about EPS, or extrapyramidal symptoms. These are caused by blocking dopamine in the midbrain to the brainstem. So things that can happen are like pseudo-Parkinson's, where the person appears to mimic things of Parkinson's: slumped posture, shuffling gait, drooling, tremors, pill rolling movement of the fingers. We could have acute dystonia, so muscle rigidity or spasms. They could have difficulties opening their mouth, or it can appear as if their gaze is locked in a particular direction. And in severe cases, they could actually have a crisis in which they're unable to control the movement of their eyes. Tardive dyskinesia, while not exclusive to antipsychotic medications, these are abnormal involuntary movements of the body. always know your symptom management of EPS. There's anticholinergic drugs like benzotropine and diphenhydramine that can reverse the EPS effects of this medication. Um, there is a scale that we use, is called the AIMS scale, the Abnormal Involuntary Movement Scale, and that is an evidence-based assessment on the level of tardive dyskinesia that the client is experiencing. Detoxification protocol. Managing treatment of a client who is experiencing withdrawal from a substance can be very complex. When chemical concentrations of a substance begin to decrease in the body, it can cause physiological and psychological effects. In your next slide, it's going to talk about alcohol. Go to the lesson on substance-related and addiction disorders in your ATI book for more information. Alcohol is a CNS depressant, and when it's consumed over long periods of time, it can actually cause a lot of problems in the body. So we get this adaptation response. When someone has a prolonged alcohol consumption, it actually decreases their GABA and increases their glutamate functioning. So we get a tolerance or a needing to increase the amount that they're taking to reach a desired effect. And we need to make sure that we manage withdrawal, because abruptly withdrawing from alcohol can actually cause death in a client. So the brain can't function without the presence of the alcohol. The brain has adapted to function with decreased inhibitory and increased excitatory function. So excessive amounts of glutamate released at that presynaptic cleft can cause the CNS to excite, increasing the heart rate, increasing the blood pressure, nausea, vomiting, seizure risk, hallucinations. So we generally give these clients benzodiazepines to bring the brain and body back down into a state of balance. So drugs like Librium, you'll see clonazepam used to keep patients from having seizure activity from the alcohol withdrawal. Next slide talks about opiates. When consumed over long periods of time, opiates will create a sense of euphoria. It will trigger the brain's adaptation response. Also, in acute opioid intoxication, reduced levels of norepinephrine can cause drowsiness and pain relief. After prolonged exposure, chronic exposure to opiates, they will alter the neuron function in the brain and release large amounts of norepinephrine. And then this adaptation response to the prolonged opioid consumption results in downregulation of the opioid receptors, resulting in desensitization of the receptor signaling, and then upregulation of the opioid metabolism. So discontinuation of opiates going through opioid withdrawal results in a huge surge of norepinephrine, which can cause muscle aches and very severe discomfort. Won't kill the patient like alcohol withdrawal will, but it is very, very unpleasant and very uncomfortable for the patient. Times that they'll go through fast opioid withdrawal is, if they get incarcerated, because they are not going to be able to obtain the opioids while they are in jail. So the last two slides, you have your Appendix 1, which goes over that image description again that we talked about what 1, 2, 3, and 4 stand for in that presynaptic neuron. And then Appendix 2 goes over the physiological effects of opioid withdrawal. So that was it for your lecture for week 2. And I look forward to recording another podcast for you for week 3.